courses task force or the subcommittee in his work. And he's obviously very passionate on education related to ultrasound. And the topic is the first trimester anomalies, and this is part 2. We've done part 1 a few weeks ago, and people were very enthusiastic and wanted to carry on with another webinar focusing on first trimester fetal anomalies. Also, I'd like to thank our sponsor, GE, for their support and supporting education activities related to ultrasound, and also driving really leadership in fetal imaging. And of course, huge thanks to the team behind the scene who make sure that these courses are organized and they sort of work smoothly, and ensure that also these webinars are recorded. So please, if you don't want to have your video on, don't turn on your camera. We mute everyone to avoid any distraction or noise. Please also, if you have children, please stop them drawings on the screen, because obviously that annoys really the people who are giving the talks, and also it's included in the recording, so that's not ideal. These webinars are recorded, they're completely free, they're available on the GeoFAC website, so you can access them. Many people are not able to join live, but they access the recording afterwards. Before I finish, I would like to maybe encourage you to engage with us. So please post your comments or questions in the chat box. We'd love to hear from you. Certainly my favorite part of the webinar is usually the discussion and the questions. So please engage with us. I'm going to stop here and I'm going to hand over to Simon to do the introduction of the first talk. But just again, the certificates, so you have a certificate of attendance, and the feedback will be at there's the QR code at the end of the webinar. Please fill in the feedback, let us know what you like, what you don't like, any topics, suggestions for future webinars. So again, welcome to another fetal medicine webinar. Huge thanks to all people involved. Simon.
Thanks very much, Asma. And just to give you some idea of the level of interest in first trimester part 1 and part 2, we have 2,500 people who have registered for this meeting, and the numbers online we have at the moment are creeping up to 400 online. And many of you, of course, joining from different parts of the globe, find it easier to watch these on demand after the event. But it's always good to have 400, and the number will continue to increase to have you online with this. And you know, the beauty about having you online is exactly that point, as Asma says, is that you join in with Q&A, and we would really appreciate if you do that. In part 2 of the first semester, we are covering the fetal limbs, the fetal brain, and specifically in the fetal brain, the posterior cranial fossa. And then we will talk about anterior abdominal wall defects, which Valdo will be covering, and Nicola will be covering posterior fossa. And then Asma, who will kickstart the meeting, will be covering fetal limb abnormalities in the first trimester. And you all know Asma. Asma's professor of fetal medicine at St. George's Hospital, but also at Liverpool Hospital. She's a trustee at ISUOG on the board. A world-renowned expert in the fetal medicine, specific interest in twin pregnancies, and a fantastic teacher and educator. So it seems only right that we kickstart this with first semester limb anomalies, and I'll hand the conch over to you, Asma.
Thank you very much. Thanks, Simon. And we're going to talk about first trimester, the fetal limbs. And if we start with embryology and we start and see when do you see this or what happens in terms of limb development, by 5 weeks, the limbs develop as out pockets from the ventrolateral body wall. And by 6 weeks, you start seeing this circular constrictions at the level of the wrist and the upper limbs, and at the level of the ankles in the lower limbs. So that would be the future sort of the creases. And then by 8 weeks, the limbs are already developed in the definitive form, which is the 3 segments, as you would recognize them. So what do you see in ultrasound scan? Well, by 8 weeks, you should expect to see the limb buds. By 9 weeks, you should be able to see the femur and the humerus. By 10 weeks, you would see the tibia, fibula, radius, and ulna. by 11 weeks, which obviously the scan, the one that sort of the traditional routine first trimester ultrasound scan, you should be able to see the digits of the hands and the feet, and the fetal movements or the body movements already start from 9 weeks. Does the appearance of the limb differ with gestation within the first trimester window? And the answer is yes. So if you do ultrasound scan prior to 10 weeks, the appearance is different. So often the limbs are straight, they tend to be short, they tend to be very close to the body. So they often, the lower limbs, they touch each other. And again, they're very close to the fetal body, to the anterior part of the fetal body. What about the upper limbs? Again, close proximity to the anterior chest wall, and the hand, they tend to maintain close proximity against the anterior chest wall. So the appearance is slightly different from the window between 11 and 13 weeks. What about the role of 3D ultrasound scan? Is it useful? And I would answer yes. In fact, particularly if you're going to do a transvaginal ultrasound scan, the resolution is better and you can obtain these beautiful images. And sometimes it's really useful, particularly when you're looking for like polydactyly, for example. What about the guidelines? What do the guidelines recommend when it comes to fetal limbs in the first trimester? Well, the old is what guideline on the first trimester ultrasound for the extremities. The recommendation is that, or the expectation is that we should demonstrate the 4 limbs, each with a 3 segment. We should demonstrate the hands and feet with normal orientation. As you are probably aware, is what updated the first trimester ultrasound recently. And now we have the minimum requirement. And the minimum requirement, again, similar to extremities, you visualize the 4 limbs, each of them is 3 segments. But also, they included a section about what other structure that could potentially be also demonstrated or visualized, so maybe a little bit more detailed. And for the extremities, again, upper limbs with the 3 segment and the movement, free movement, and the lower limbs, again, with 3 segments and the free movements. Do we need to measure the long bones in the limbs? Well, again, in the ISWA guideline, the updated one, the female length could be measured in the long axis, the calipers placed at each side of the ossified diaphysis. And why would you measure it? Because potentially you could actually diagnose or pick up early the cases of early severe skeletal anomalies. Another guideline that also was published in the last couple of years is WAPM, or the World Association of Perinatal Medicine. So they published a guideline in the first trimester, and Nicola led on this guideline. And in this guideline, we had a list of, for each sort of the fetal organs, what would be recommended and what would be suggested. And for the fetal limbs, demonstrating the 3 segments as recommended, and we do that in the axial or the sagittal plane. I need to be able to demonstrate all the bones and the fact that they have regular proportion. And when you demonstrate these views, you would be able possible anomalies that you can actually detect to be the limb reduction defects and skeletal dysplasias. What about the hands and the feet? Again, was recommended that you should be able to demonstrate the hands and feet. And again, the axial and sagittal, you need to demonstrate that they are present, and you could pick up the limb reduction defects, which are the commonest fetal limb anomalies detected in the first trimester. Also, you need to look at active movements, and again, that's recommended. And the active movements, you need to demonstrate flexion and extension. And obviously, if you do that, you will pick up things like neuromuscular anomalies or fetal akinesia sequence. Fetal arthrogryposis in the first trimester, and this is a case I saw recently, where you would actually see that the limited fetal movements, I hope the videos are working, yeah, limited fetal movements, and when you see the lower limbs, you have the knees extended and sometimes crossed, while actually the upper limbs or the arms, they tend to be flexed and on each side of the thorax. If you see that, look for associated anomalies. So the ultrasound scan, and the things that we look for, particularly things like micrognathia, These cases are commonly associated with increased nuchal translucency, can have narrow chest, and the presence of polyhydramnios not really seen in the first trimester, often not seen before 25 weeks. When you see fetal arthrogryposis in the first trimester, there's a long list of potential causes. Obviously, on top of the list is aneuploidy, like trisomy 18 or 8, but there are more than 150 genetic syndromes that could be associated. I mentioned just 4 here, and it's important to mention that many of these genetic syndromes can be autosomal recessive with a risk of recurrence of 1 in 4. So in this case, make sure that you involve your genetic colleague. I think really looking at the digits is probably best, in my opinion, in the first trimester, because the baby is not closing their hands, and therefore you'll be able to count the 5 fingers. So really first trimester ultrasound is a golden opportunity to examine the hands and the feet. Many of you will be very familiar with this slide. Is that what fetal abnormalities that we always detected in the first trimester, and fetal anomaly or fetal limb anomalies is not really included in this list, like cranial, encephalic, zonflex, gastroschisis, mecacystis, body sulc anomalies that are not always detected in the first trimester. So what is the detection rate of fetal limb anomalies in the first trimester? What you see from the same data from the study by Argyros and Glacki, and the absent hands and feet detection rate was about 60% in the first trimester. So why is that? Why we're not really able, if the guidelines already recommend that demonstrating the limbs should be as recommended in the first trimester, why we're not able to detect all fetal limb anomalies in the first trimester? Because actually it's challenging. Why? Because a lot of these anomalies tend to be rare. If you look at the literature, most of the condition only have few case reports, often require additional investigation really to reach the final diagnosis. Sometimes maybe it's incidental finding. And what really the key message is that you need to have a systemic, also to be systematic in your examination. So when you suspect there's fetal limb or skeletal anomalies, in this case, you need to assess the limbs. And when you assess a limb, you look at the biometry, the lens, you describe the shape systematically, you look at the mineralization of these limbs and comment on the movements. Not enough to look at the limbs only, but also you look at the associated anomalies or the other systems, and particularly commenting on the fetal head, the thorax, the spine, the heart, and the kidneys. So when you find the fetal limb anomalies, particularly in the context of associated abnormalities, you offer genetic testing. So in the past, we used to do obviously the karyotype or the array, but nowadays we are doing exomes. So what is the additional yield when you do the exomes when it comes to fetal skeletal dysplasias, for example, skeletal anomalies? The additional yield has been described in the literature about 70%, but of course that varies, or if it's an isolated short long bones, or if it's non-isolated. Of course, if non-isolated, the yield will be higher, so about nearly 80% compared to about 70% when it's isolated short long bones. And of course, the features, or what's been shown in the literature, the feature with the highest additional diagnostic yield is when you have an abnormal skull, so about more than 80% of them have, they can have genetic abnormalities picked up on the exome, or when you have a small chest, again, about 80%. How do they look like when you have short, long bones in the first trimester? And I'm just going to show you this case. It's almost like dots, sort of this femur becomes like almost this white echogenic dots. So be familiar. The more you see anomalies, the more you'll be able to pick up these cases. When I mentioned that the ISWAC first trimester guideline did say that we could measure the femur length, what about the charts? And you can see here the charts. Of course, the length varies with gestation, but certainly if you measure the femur length less than 10 millimeter in the first trimester, between 11 to 14 weeks, that could be quite short femur. The mineralization, again, see here, so normally you would see the nice skull, echogenic, surrounding the brain, but in case of hypomineralization, in this case, you can see sort of the brain becomes a bit more easier to see, and the skull is really hypomineralized. And if you have that in the first trimester, really think of these three conditions: achondrogenesis, hypophosphatasia, or osteogenesis imperfecta. What about serinomelia, which is should be really first trimester diagnosis? When you have this fusion of the lower limbs, often have bilateral renal agenesis and have single umbilical artery. They can have associated genital abnormalities. They can have oligohydramnias, which is not always seen in the first trimester. But certainly first trimester ultrasound scan, it should be a first trimester ultrasound scan diagnosis, is mostly lethal. And don't forget that the list of differential diagnoses, including caudal regression syndrome, it can also be sporadic, and if it is, can be associated with maternal diabetes. They often have normal karyotype with low risk of recurrence. So again, this is the case of serinomelia in the first trimester. And you see here the two femur and then the fused lower part of the lower limbs. And this is the quality of the video is not great, but you see here the fused lower limbs. And this is a post-mortem picture. What is the most common abnormality of fetal limb abnormalities that are detected in the first trimester? I did mention earlier is a limb reduction defects, and obviously can vary in terms of whether it affects unilateral or bilateral, whether it affect the upper limbs or the lower limbs. But I'm going to show you some of it. So, and to just be familiar with the terminology. So amelia means complete absence of the limbs. Here is a 3D image, and we see sort of complete absence, while a sharia or acaria, when you have absence of the hands, like here, for example. So here, absence of the hand, which is distal transverse limb reduction or amputation. It's usually, if it's affecting the upper limbs, it's usually an isolated anomaly, while when you have it in the legs or the lower limbs, particularly if it's a bilateral, be careful, it could be part of a genetic syndrome. So look for associated abnormalities and consider offering genetic testing. The limb reduction defects, it relatively is the commonest fetal limb anomalies that be detected in the first trimester, but it's still quite rare. It's only 1 in 20,000. And about 50% of them tend to be multiple, 25%, 1 in 4 associated with associated abnormalities. And this is some of the syndromes, aglossia, adactylia syndrome, or the Mobius sequence. But there are other causes, so they're not always caused by genetic anomalies. Other causes, amniotic band syndrome, exposure to a teratogen, so ask about the drug history, or vascular accident. And amniotic band syndrome, you have to be really careful because sometimes it's actually difficult to demonstrate the amniotic band itself. It's often very, very thin. It is true that when you think that maybe amniotic band syndrome, you're looking for the limbs, you're looking for the digits, but actually also it can affect other parts of the fetal body. So they can have craniofacial region, they can affect the trunk, even they can affect the umbilical cord and can result in intrauterine fetal death. As I mentioned earlier, the bands can be very thin, and therefore, in order to diagnose amniotic band syndrome, it's not essential or it's not mandatory that you actually see the bands themselves. You should try. But certainly if you have absent digits or portion of the limbs, and the other thing, which I'm going to show you, when you follow up this case and look at the natural history, you can actually, because of this constriction band, impairing the venous blood flow before eventually it impair the arterial blood flow, causing ischemia, and that what will lead to amputation if you don't release this constricted band. And therefore, initially, when you follow up the pregnancy, you might actually see the swollen distal arm or leg before you see the amputation. So this is a case with in the first trimester, so about 13 weeks, and you see sort of amniotic band is actually very, very thin. That's a transvaginal ultrasound scan. And then you see there is absent digits for a portion of the limbs. And then as you follow up, this pregnancy is 13 weeks. So you're seeing the digits of the hands being affected. Then at 16 weeks, you see here the swollen foot because of the restriction band around the ankle. And then this will, again, as you follow up the pregnancy, so it's a couple that were really keen, were very committed to pregnancy. They wanted everything done. We discussed the option of fetoscopic excision of the amniotic band, but we would do it usually about 18 weeks because we're doing fetoscopically. So we waited, we monitored. So 17 weeks, you can see this is swollen foot. Here you can see already sort of oligodactyly were missing, or sort of missing some of the fingers. And this was a fetoscopy, and you see here, this is the amniotic band, and this is when we excised the amniotic band. And this case was included in a documentary, the Channel 4 documentary that we had, Baby Surgeons Delivering Miracles, which was viewed by millions of people. This baby is doing very well now. It's about a few years old. So the amniotic band syndrome, I think, is important. Obviously, I'm showing you a case that involving the extremities or the limbs. But as I mentioned earlier, be careful, because not just the limbs also affect other parts of the fetal body, the craniofacial region, and can cause facial cleft or asymmetric microphthalmia or encephalocele. It can affect also the trunk, resulting in anterior abdominal wall defects. But the most extreme manifestation is the body stalk anomaly, which again is a first trimester diagnosis. So back again to the limb reduction defects, and I did say it could be, yes, it could be associated with genetic syndrome, particularly when you have associated abnormalities. It could be isolated. There could be other causes like the amniotic band syndrome. It also could be the teratogens or the drugs, and therefore it's important to ask about the drug history. And this table shows a list of drugs that could be associated or could cause limb reduction defects, things like, for example, cocaine. What about the phocomelia, or the other name is the seal limb? And be careful, because also could be associated with a genetic syndrome. I listed here 3 of them. So Roper syndrome, which is autosomal recessive, the thrombocytopenia absent radius syndrome, and the grip syndrome, which is also autosomal recessive, which is often the limbs, both the upper and lower limbs are very, very short, but the lower limbs are more affected than the upper limbs. This is a grip syndrome, autosomal recessive, and as I mentioned, is often the lower limbs, very, very short, and more severely affected than the upper limbs. What about the club hands? So the club hands could be radial club hand or could be ulnar club hand. The radial club hand, you see it when you have radial aplasia, and therefore the hands are sort of deviated to one side, and it also can have absent or hypoplastic thumb. The ulnar club hand, so the other direction, and that can range from sort of mild deviation of the hand to the ulnar side of the forearm, or complete absence of the ulnar. I think it's important to realize that when you have a radial club hand, be careful, because it's commonly associated with other genetic conditions or syndromes, while the ulnar club hand is usually isolated. And here's some of the a list of some of the abnormalities or syndromes that can be associated with a radial club hand, things like trisomy 18, the thrombocytopenia absent radius, Holt-Oram syndrome, which you can have, would often have radioplasia, but they can have also heart abnormalities, while the Roper syndrome, which is autosomal recessive, as I mentioned earlier, they can have phocomelia, they can have facial cleft, and they can have also heart abnormalities. So this is a case of, this is Simon's case, thrombocytopenia, absent radius syndrome. You see here, this is a club hand. Here, you see, this is what you see here. The bone is ulnar, while the radius is absent. You see here sort of again the position of the hand, and here this is a 3D image. So something, again, if you follow the guidelines, when you're supposed to demonstrate the 3 segments of the upper limb and demonstrate the hands, you should be able to pick it up in the first trimester. There is differential diagnosis of cases of TAR. So Fanconi anemia, and the one useful feature to help you to distinguish is that they tend to have absent thumbs. The Holt-Oram syndrome, the distinguishing feature, they tend to commonly have heart abnormalities. The Cornelia de Lange syndrome, which is often they're small for gestational age, but unlikely going to see that in the first trimester. That's often later in pregnancy, but they can have facial defect. They tend to have micrognathia. The Nigger syndrome, they have mandibular hypoplasia and abnormal ears. Of course, the trisomy 18 and 13. So trisomy 18, they can have radial club hand. Other conditions, the Vater association, and the Roper syndrome, as I mentioned earlier. Other fetal limb anomalies, of course, is the polydactyly, and the polydactyly could be post-axial, it could be pre-axial, but also can be central. The post-axial, often isolated disorder, is often autosomal dominant, and you see it more likely in Afro-Caribbean. So when you have, or you see it in the first trimester, ask for family history, for example. Sometimes the mother herself said, yeah, I was born with that and I removed it, for example, had it excised, or yes, it runs in the family. When you have a post-axial polydactyly, particularly in white ethnic background, be careful because it could be syndromic and could be autosomal recessive. When you have a polydactyly, it could be the whole digit, with including also the bones or the phalanges, but it could be just a fleshy or just a soft tissue, so fleshy nubbin. I mentioned earlier, could both be post-axial, could be pre-axial. It also could be central. That's not very common, but it's usually hidden between the long bones and the ring finger. They can be bilateral, they can be autosomal dominant, and associated with hand and foot malformations. When you have polydactyly, yes, it could be isolated, but also could be associated, and in fact, commonly associated with other genetic syndromes. Almost all of them are autosomal recessive, and often the case when you suspect it, when you have associated abnormalities. And here I mentioned 4 of these genetic syndromes, a Meckel-Gruber, of course, Meckel-Gruber, when you have the encephalocele, often occipital encephalocele, and when you have polydactyly, look at the kidneys, you have polycystic kidneys, and it's also recessive. The Bardet-Biedl syndrome, and sometimes in Bardet-Biedl syndrome, the only thing that you pick up in the first trimester is the polydactyly. You might not see the echogenic kidneys until later in pregnancy. The short rib polydactyly syndrome, when you have the polydactyly, but one of the things that make you suspicious is when you have short long bones or short femur. You can have small thorax that can be demonstrated in the first trimester. They can have heart abnormalities, you can have polycystic or renal abnormalities, and the ribs can also be short, but that's not always very clear in the first trimester. So even if you don't have short ribs in the first trimester, it's still, but you have polydactyly and you have short femur, it still could be short rib polydactyly syndrome, which is very important to differentiate from the thanatophoric dysplasia, which often have also short femur or short limbs in the first trimester, because thanatophoric dysplasia is autosomal dominant with very low risk of recurrence, while actually short rib polydactyly is autosomal recessive with 1 in 4 risk of recurrence. The Ellis-Van Creveld syndrome, again, you will you can have polydactyly, you can have short limbs, narrow chest, and you can have heart abnormalities. This is a case of Meckel-Gruber syndrome when the genetic testing was performed with pathogenic variant in this TXNDC15 gene. And you see here, you can see the polydactyly, you see the occipital encephalocele. Sometimes you really need to do transvaginal ultrasound scan to be able to see the polydactyly clearly or look for it carefully. And also look for the occipital encephalocele and for the cystic kidneys. And this is a post-mortem picture of this baby, which is already published. And oligodactyly, so you have polydactyly, the opposite would be oligodactyly. And again, similar to polydactyly, it could be associated with genetic syndrome. So look for associated abnormalities. Syndactyly, when you have 2 or more digits are fused, and they could be, the bones are fused, but could be also the soft tissues tend to be fused. And again, syndactyly is commonly associated with abnormalities. They can also be mostly isolated. Chromosome abnormalities could be triploidy, but of course in triploidy you will see a lot of other abnormalities that you can easily make you suspicious of the diagnosis. Genetic syndromes could be the Apert syndrome, Carpenter syndrome, Frasen syndrome. A lot of these syndromes, you might not really see the associated abnormalities easily in the first trimester. So, for example, in Fraser syndrome, you can have bilateral agenesis, not always, but you can have it. You can have microphthalmia. You can have obviously the tracheal atresia, but as I mentioned, they tend to be autosomal recessive with risk of recurrence of 1 in 4, but not all of these features will be obvious in the first trimester. What about ectrodactyly? And certainly if you see a case of ectrodactyly, you will never forget it. It's almost like lobster claw deformity. And ectrodactyly or EEC syndrome, ectrodactyly ectodermal dysplasia, or the cleft syndrome, or the other terminology is a split hand, split foot, ectodermal dysplasia, cleft syndrome. For the EE syndrome, it's autosomal dominant with about 50% risk of recurrence, affect the 4 extremities. They tend to be more severe deformities in the hands. They can also have facial cleft, and they can have other ectodermal defects, which you might not be able to see it in ultrasound scan. Other limb abnormalities that could be markers of chromosomal abnormalities, of course, the clenched hands in trisomy 18, the Sandel gap in trisomy 21. What about clinodactyly, which is relatively common, not always associated, could be isolated, could be associated with aneuploidy, particularly with Down syndrome. It can be bilateral, which essentially the description is medial deviation or radial curving of the finger at the distal interpharyngeal joint, and usually affecting the 5th finger. What about if you have a ducted thumb in the first trimester? And this is, you can see here, this is the first trimester, you can see that ducted thumb. This case was bilateral, and it was when the follow-up ultrasound scan, so 18 weeks, when this fetus developed bilateral ventriculomegaly, and the genetic testing showed the L1 CAM variant. And so this deletion, so that was a paper that was published where highlighting the fact that seeing a ducted thumb in the first trimester could be an early clue to the diagnosis of L1 syndrome, which is obviously X-linked. In this case, take a history and maybe offer genetic testing. And it might be a useful clue if you had a previous affected pregnancy and you're doing first trimester ultrasound scan and you're looking for risk of recurrence, maybe look at the thumb. What about talibus or clubfoot? And clubfoot can be difficult to demonstrate in a first trimester for a number of reasons, because the ankle joint is not calcified early in gestation. You might be able to demonstrate it using a 3D ultrasound, but it's also important that when you have normal ankles, or the position of the ankles is normal in the first trimester, that does not rule out the diagnosis of talibus later in pregnancy. So I would say it's a difficult diagnosis in the first trimester, maybe doing 3D ultrasound, but certainly a first trimester ultrasound where you have the ankles appear normal. In the second trimester, you can actually have a baby that has been diagnosed with clubfoot or talibus. What about fetal akinesia deformation sequence? And as I mentioned in the guidelines, they did recommend that you also demonstrate or comment on the fetus that the fetus have normal limb movement. The fetal akinesia deformation, due to a number of abnormalities, whether neurological or muscular, connective tissue, or skeletal, they tend to have to be bilateral. They can have hydrops in the first trimester. You can see here talibus, and often have increased nuchal translucency. The joints abnormalities, the fixed flexion, or could also be extension deformities, and they can affect multiple joints. They're usually symmetrical, so all 4 limbs are involved. And as I mentioned earlier, the polyhedramness, you're not going to see that in the first trimester. You don't see it until the 3rd trimester after 25 weeks. The reason I was developed interest in fetal skeletal dysplasia, so fetal limb abnormalities, is that many years ago during my training, I worked with Professor Linchiti, and we had a specialist clinic in UCH where we used to have many, many cases referred from across the country in the UK with skeletal abnormalities. And we published this paper more than 10 years ago about the early features or early diagnosis of skeletal anomalies or skeletal dysplasias. And in this paper, we included this long list of skeletal dysplasias, and we described the feature that you see in the first trimester. I think it's important to highlight that, of course, a lot of these cases were maybe had previous affected pregnancies, so they were referred or they came because we're looking for recurrence. But it's also true, and it's important to mention, that most skeletal dysplasias are not really picked up in the first trimester and only picked up later in pregnancy. So what are the features that you can see in the first trimester? Well, commonly they are, or a common finding in cases of secreted dysplasia is a thick nuchal translucency. And therefore, if you see thickened nuchal, of course, you will look for associated abnormalities. So don't forget to look for signs of skeletal dysplasia, including the short femur or the bent or bowed femur. And sometimes you can see signs of the fractures of the long bones in the first trimester. Of course, as I mentioned, you comment on the mineralization of the bones, but also you comment on the size of the thorax or the chest. You comment on also the ribs, and how do you see or you comment on a small chest in the first trimester. You see this almost bell-shaped chest. So that's a feature or suggestive of a small thorax in the first trimester. Other things, so commenting on the hands and the feet, because as I mentioned earlier, they can have polydactyly, they can have oligodactyly, they can have the hitchhiker thumb, and they can have absent radius, they can have club hands, for example, or they can have the cleft hands or even absent hands or feet. And they commonly can have spine abnormalities, which are not very easy to demonstrate in the first trimester. And I'm just going to finish my talk by showing you some of these features in the first trimester. So osteogenesis imperfecta type 2 at 12 weeks. So you can see here the femur is short, and often the barber diameter in this case was on the 95th centile. And if you see this a transvaginal ultrasound scan, you see the short bent femur, also the tibia and the fibula, abnormal foot position, the small chest that I showed you earlier, the bell-shaped chest, and this is a 3D image. For both the osteogenesis imperfecta and the short rib polydactyly, you can have short ribs, which can be demonstrated in the transverse section of the fetal chest. Here, this is small chest, and I'm just showing you images so that you're familiar with how the appearance of these features in first trimester. For the hitchhiker, sorry, the thanatophoric dysplasia, again, short, both long bones in the first trimester, that normal skull shape. You can see also the starting features of the frontal bossing, which you can see that in the first trimester as well, if you look for it. So the thanatophoric dysplasia is the commonest lethal skeletal dysplasia, and again, you should be able to diagnose it in the first trimester. And in this case, when you do genetic testing, you're looking for mutation in the FGFR3 gene compared to osteogenesis imperfecta, which is mainly really, you're looking for mutation in the COL1A1 or COL1A2 genes. And for osteogenesis imperfecta, of course, there are different types and they vary in the severity. But if you have, for example, type 2, which is one of the severe forms of osteogenesis imperfecta, you might see the hypomineralization of the skull. You see the short, bent, long bones because there's fractures and healed. And here's a cross-section of the axial view of the fetal skull. You can see the hypomineralization of the skull bone. The hitchhiker thumb, which you see it in the first trimester, and that's a characteristic of the dystrophic dysplasia. They also can have abnormal lower limbs with a position. You can see that, and also they have short femur, the short rib polydactyly, as well as the Ellis Van Creveld. You can have short ribs, can have polydactyly. You can see here in this image. They can have, of course, the short long bones. And finally, the campomelic dysplasia, not commonly diagnosed in the first trimester. It's because the result from the SOX9 gene mutation. And again, you have the short bowed femur. But two characteristic features of the campomelic, they tend to have hypoplastic scapula, so very small scapula compared to the normal scapula. And also the genitalia, so appears maybe on ultrasound scan as a female genitalia, but when you test for genetics, it's actually a male fetus. So I'm going to stop here. It's a lot to cover. Fetal limb or skeletal abnormalities in the first trimester is one of the difficult and maybe complex. I hope that I try to make it simple. So I'm going to stop here and happy to take any questions.
Thanks very much, Asma, for a stellar talk, as always. And as Asma concluded, a very difficult topic, but it was covered beautifully in that 30 minutes, covering from both the focal anomalies through to the generalized skeletal anomalies. And we had sort of an agreement that we were going to move on to our next speaker and then stop for Q&A, but I'm going to break the rules, Asma, and just ask a quick question. You started off by making the comment of the role of exome sequencing in skeletal anomalies. And I'd like you just maybe to pass comment about the importance of first trimester diagnosis in this new world of exome sequencing, and why it becomes so important. And if I could just add an addendum to the question, because I think the audience will want to know this, the addendum to the question is does that data on exome sequencing apply to generalized skeletal dysplasias, or does it also include the focal skeletal dysplasias, most of which you pick in the first semester, but the generalized you generally don't? If you could just comment on that.
Yeah, so this is a really good question, because traditionally, what you do is that in the first trimester, for example, if you have increased nuchal translucency, depending on the cutoff, particularly if you have associated anomalies, you would do offer genetic testing, and until a few years ago, you would do the array. And if the array come back as negative, so they have not identified abnormality, you are going to carry on with the pregnancy and follow up, also of doing detailed anatomy scans, but you don't really have a genetic, or you don't have really a diagnosis for this fetus. So it's difficult really to tell the parents, apart from you relying on what you see on ultrasound scan only. While actually exomes, at least in the UK where I practice, is not automatic. So it's not like something that we can offer to all the patients. So we have eligibility criteria. So for example, if you have a nuchal translucency of 4, and maybe, one, let's say polydactyly, maybe perhaps that's not enough to qualify for exome. And that, to some extent, puts a responsibility back on us, so that I need to do really detailed an ultrasound scan in the first trimester to be able to identify any other abnormalities to guide the genetic testing. That might not be necessarily the case in other countries. I believe Germany, I think they can have exomes, maybe more liberally, while in the UK we need to justify it. And therefore, I think that's with more emphasis on detailed anatomy scan in the first trimester, so you can actually obtain accurate genetic diagnosis as early as possible in the first trimester.
Yeah, perfect. Thanks very much, Asma, for an absolutely brilliant presentation. So we move now on to our next speaker, Valdo Sepulveda, who's also known to you all, and Asma has already introduced Valdo, who's a maternal-fetal medicine specialist and the director of the Diagnostic Center in Fetal Medicine in Santiago in Chile. Now, many of you will know Valdo from his work in terms of what he's published in the first semester. And in fact, Valdo's got over 400 publications to his name, and many of these are in the first semester. And Valdo has had many first reporting of anomalies in the first semester of pregnancy. So there's nobody better qualified to cover the next topic, which is ventral abdominal wall defects during the first semester. Valdo, it's an absolute pleasure to have you with us today, and I'll hand the conch over to you. And as we were talking briefly while Valdo's bringing up his presentation, many of you will know the facts and figures related to abdominal wall defects such as omphalocele and gastroschisis. And we had a quick chat beforehand. Some of that basic data, which many of you are aware about, we might skip past. So Valdo will be concentrating more on the supraumbilical abdominal wall defects, namely the cardiac extrophy, sternal defects, and then moving on to the infraumbilical defects, covering the from bladder extrophy to cloacal extrophy to the OIES complex, which are always a very challenging diagnosis to distinguish between these. So with that said, I will hand over to Valdo, who's got his presentation ready to go. We can't hear you, Valdo. Just to check the mic's unmuted. I still can't hear you.
Okay, can you hear me?
Yes.
Now we've got you. We've got you now, Valdo. Yep, over to you.
Do you have my presentation screen?
Yes. Yes.
Yes. Yes,
Okay.
we do. We've got a video clip of a 13-week pregnancy nuchal translucency scan. You're starting with that.
Okay, thank you very much for the invitation. Thank you, Asma. Thank you, Simon. Thank you, Nicola, for the opportunity to join you in this very important topic that is getting, bigger and bigger. And actually, we're looking for so many things right now that actually we're transporting the second trimester scanning to the first trimester. That's a good goal for the obstetrics and gynecologists and the maternal fetal medicine specialists, because actually, what the human want is just to have an early diagnosis. And ultrasound is playing a very, very pivotal role in this task. I'm going to talk about anterior body wall defect. I'm going to cover from ectopia cordis to bladder extrophy. And just to start, we are going to see this picture is an old video clip that you can see from 2011 that actually I was receiving this patient for assessment, and you can see that actually was really a very easy diagnosis to make, and there was the heart pumping outside the fetal chest. The diagnosis is very simple. This is a typical thoracic ectopia cordis, and you can see that the baby looks otherwise absolutely normal. And here you can see that you have the pulsatile mass outside the chest, and also an intact anterior abdominal wall. That's very important because you can confound this with the thoraco-abdominal ectopia cordis. And we also note that actually there was a normal nuchal translucency over here. And you can see that's very important because actually most of the cardiac malformations present with increased nuchal translucency. But in this case, one of the most severe malformation, actually the nuchal translucency was absolutely normal. This is the axial plane. You can see that more than 75% of the heart is outside the fetal chest. And if you use color Doppler, you can see the flow in and out, the main vessel over there. You can see the aorta. And also it's very impressive to see this finding. This is a very serious condition. And you can see that actually, presented with normal nuchal translucency and even a normal ductus venosus. That actually is not in keeping with cardiac malformation detected in the first trimester. This is at 28 and 33 weeks. You can see that the heart looked completely abnormal over here. The patient continued the pregnancy and she didn't want to have termination. And when you see the baby, when the baby was born, you can see here that actually, you can see the lungs, you can see the hole in the middle of the chest, because actually they don't have a sternum over there. The sternal bones is missing, and there you have absolutely, the heart pumping outside the brain. The baby died, at 6 hours of life. What we know about, ectopia cordis is a very rare malformation. The prevalence is about 5 to 8 in 1,000 newborn infants, and it could be complete or partial displacement of the heart outside the fetal thorax. And it's classified according to Amato in 5 types. That actually the most common one are the thoracic and the thoraco-abdominal types of ectopia cordis. Here, that actually when you look at the embryology of ectopia cordis, all of us had ectopia cordis early in pregnancy. If you have a baby less than 2 millimeters, you can see that the heart is outside the fetal body. And then the baby had an infolding, and then the heart is going into the chest. But actually, if something happened at the level of the sternum, the heart will be outside the fetal chest throughout pregnancy over there. And these are the types, but actually, just concentrate in the one on thoracic and thoracoabdominal, which has more than 98% of the cases. The other one are really, really rare, and they are not described in the prenatal literature, but you can see here that this is the one that actually, you may see quite often. And this is the way that actually the sternum forms, and you can see here that at the end, this gap is filled up with the body of the mesoderm, and you have here the manubrium and the body. And then when you have an absence of this bone over here, you will have an ectopia cordis already. Some question about ectopia cordis. There is a very common misinformation about pentalogy of Cantrell. And let me expand a little bit on this, because actually, there is a question about if ectopia cordis is part of the pentalogy of Cantrell. For example, in this publication from people from Brazil, you can see that normally they put this because it's quite striking to see the heart and the liver outside the chest, and they call this pentalogy of Cantrell, especially when you find this in the first trimester. But if you just go into the original paper from Cantrell, you can see that actually, there is no ectopia cordis as a criterion for pentalogy of Cantrell. They have supraumbilical omphalocele, lower sternal defect, not the whole sternal is missing. There is a defect in the central tendon of the diaphragm, defect in the pericardium, and also an intracardiac anomaly. And that was described by Cantrell back in 1958. And if you have the chance to see the paper, that actually you can download it from the internet. This is the main paper. Cantrell at that time was a fellow from Professor Ravitch. And you can see that actually, the paper make his name very famous. And you can see they present several cases at different ages. And this is the list that actually you can have. These are the taken from the paper about the criteria. And if you look at the 5 cases they presented in this paper, only one was diagnosed at birth. And you can see here there is a huge umbilical cord cyst and also part of the liver outside the abdomen over there. And you can see that most of the other ones were really not associated with ectopia cordis. One at 16 years of age, and the other 5 months and 6 months and 2 years. You can see here that actually is not the typical case of pentalogy of Cantrell that we notice. And let me tell you something about what it says in the paper. Previously, patients with this combination of anomaly have been considered to be examples of ectopia cordis because of the abnormality exposed position of the heart. But actually, if you just look deep into the discussion, they say that the heart usually lies in normal relationship to the other thoracic viscera. That means it's excluding ectopia cordis from the pentalogy of Cantrell. And at the end of one of the main paragraph, the discussion paragraph, Cantrell says that it is inadequate and inaccurate to consider such patient as example of ectopia cordis. Just to make this brief, ectopia cordis is another malformation associated with pentalogy of Cantrell, but actually you need to put the right name on the condition that actually is a thoracoabdominal ectopia cordis. The other question is, this ectopia cordis is a lethal condition. And actually, this was a video clip that I took when I was visiting Asia. This was in the news several times a day. That's why I had the chance just to take this information. And this was a baby from a very rural area that survived ectopia cordis. At that time, he was 8 to 10 years of age or something like that. He didn't need an operation. He was living a normal life over there. And if you look here, we can say that actually occasionally they are survivors, with or without surgery. And it's very important to count this because actually you can make the prognosis when you get the information from the ultrasound. That means ultrasound is very important to make also, to decide if this is going to be a lethal condition or not. The other question is ectopia cordis rare? And actually, it's not so rare as you normally think. This was done several years ago. And actually, when I have this, I check in the Medline, and you can see that there were 280 cases or reports on ectopia cordis. But actually, when I check YouTube, that actually there were hundreds of video clips showing this condition. There were 157. That means that there is not the normally ordinary people, the lay people is just publishing this in YouTube and not in Medline, obviously. Therefore, is ectopia cordis extremely rare? Probably it's not. And actually, you can see that in many cases ending in abortion, you will see that actually there was an ectopia cordis in these fetuses. There is more information on ectopia cordis in YouTube than in PubMed. Probably we need to include YouTube when you are searching about this condition. And the last review on PubMed, there were less than 300 cases in the medical literature. And probably it's a frequent condition in early pregnancy with high early intrauterine mortality rates that actually we have seen this thing. Are you able to diagnose ectopia cordis early in pregnancy? Yes, you are. If you look, this is a report that we put 3 cases together with Elena Andreeva and Dr. Machado. And actually, we presented 3 cases diagnosed before 9 weeks of gestation. And let me show you the information. This is one case over here. You can see that the embryo is very, very small and curved. And you can see another one looking for the yolk sac, the embryo, and the ectopia cordis just in the top of here. And this is another case at about 10 weeks from Dr. Andreeva. And you can see here what happened with all of this. All end up in intrauterine death 1 week after the diagnosis. That means that we did the follow-up scan. All of these babies were dead at that time. None of them survived. And this is the video clip that actually, I got from Karina Kaiden-Haratz from Tel Aviv, that actually you can see here that it's very easy to diagnose that the heart is just pumping outside the head. The same happened to this baby, intrauterine death at the follow-up scan 1 week later. You can see it's very easy to make the diagnosis with transvaginal scan. Well, we also know that ectopia cordis is not associated with aneuploidy, but actually, we saw this case at 12 weeks. This was a diagnosis made by Dr. Ricardo Diaz from Santiago. You can see here that the liver is outside the abdomen, and also the heart is outside the thorax over there. You can see in the top of the abdominal defect is over there in this case. If you look here, this baby is the same at 13 weeks, exactly the same with the heart pumping at the top of the defect. When you put Doppler, you can confirm the diagnosis. And actually, this is the baby after termination of the pregnancy. This is the heart and the liver over there, the heart and the liver. And this baby got, trisomy 18. And we published this case with the review of the literature and only found just few cases of ectopia cordis associated with thoraco-abdominal defects. And actually, they were all associated with trisomy 18. And probably the association between trisomy 18 and ectopia cordis is due to the omphalocele rather than to the ectopia cordis itself. We put together several cases, 7 cases, several years ago in the Journal of Ultrasound in Medicine, trying to find out about, the characteristic of ectopia cordis in the first semester, and look at, there were only one case of the true ectopia cordis, thoracic type. There were 4 associated with large omphalocele, the so-called pentalogy of Cantrell, but actually thoraco-abdominal ectopia cordis. And there were 2 cases associated with the thoraco-abdominal schisis. That actually, this is the reason why there were so many other abnormalities. There were no chromosomal abnormalities, and all of the babies, died. One of the babies that was born alive died at 3 months of age because actually it was not possible to reduce the liver inside the abdominal wall, and the baby died from sepsis 3 months ago, as I mentioned. These are thoracoabdominal ectopia cordis. You can see here, this is in the top of the chest. This is the ultrasound just before referral at 13 weeks. You can see that about 50% of the heart is inside the defect over there. And this is another case that we saw at 11 weeks, 3 days. That actually is the same. This is the video clip. The heart is pumping outside. The diagnosis is quite easy to do. And you should do this every time that you're checking for a big omphalocele, especially when the liver is out there. This is the same case at 11 weeks. And you can see that the diagnosis is quite easy to perform. Also look for body stock anomaly, because actually you may have a huge defect involving the liver, but actually sometimes, even the heart is outside and inside the defect over there. Therefore, the diagnosis of ectopia cordis is being easily established during the first trimester. All of the cases should be diagnosed at this gestational age. And those containing the liver, fetuses with large omphalocele should be carefully scanned to determine the exact location of the heart. In agreement with the current available literature, the prognosis of ectopia cordis still is a very, very poor prognosis. Most of the babies are going to die for different problems over here. What's about the fetal abdomen? I'm going to go in very quick of this. Please remember that there is a physiological hernia before 11 to 12 weeks that you need to check and you need to see every time that you are scanning this baby for the insertion of the umbilical cord. And these are the 4 cases that actually an abdominal wall defect is pathological, even if diagnosed before 11 weeks. If you see gastroschisis, if you see that it contains the liver, if there is ectopia cordis, or it is associated with kyphos scoliosis, that means that you can make the diagnosis before 11 weeks. And in any way, it's important to do the follow-up scan in these cases over there. This is the case. You can see here liver and also a large ectopia cordis. Another one that actually, is about 13 weeks. You can see here the liver, a huge abdominal cyst over there, a very short cord. And you see there that actually there is no straight spine, but actually it's very difficult to see, very short and very deformed spine over there in a case of a body stock anomaly. And this is the picture of the baby. You can see that most of them are associated with the amniotic band syndrome, with some cases of amputations. In this case, laparoschisis and also amputation of the left leg. Just going very quick about this, you should differentiate this with the liver containing omphalocele and the one that actually they do not contain liver, but actually the prognosis is quite different over there. Some of these will resolve in the next ultrasound scan. You can see here very small areas over there. And if it is associated with the eye drops, you should think in trisomy 18, as in this case. Here there is another one with megacystis. It's another association associated with trisomy 18. And this is a normal case at 11 for 4 weeks. You can see here thickening of the proximal section of the umbilical cord, some of the loops of the bowel over here, small bowel, and also you can see the difference between, the thickness of the cord over here and over here. This is because of edema and the presence of the cases of the loops of bowel. Here, in case of a large omphalocele, you can see that even the omphalocele is bigger than the abdominal circumference itself. And if you look at the 3D ultrasound, you will see this quite easy to do the diagnosis. These are very difficult to reduce postnatally. That means that you need to be aware that is associated with the high morbidity rates over here, especially when you have, increased nuchal translucency. Then you need to check the heart, the anatomy, the heart anatomy very, very closely in these cases over here. This is the same case as before, and this is the management about the use of omphalocele. You need to find out contains liver, contains heart, kyphoid scoliosis, umbilical cord, nuchal translucency, and other findings. You should do a karyotype of NIPT, and then a second trimester full anomaly scan and fetal echocardiography. This is a case that is different, that you can see only bowels are floating free in the amniotic cavity over there. This is the axial view, and the diagnosis, the differential diagnosis made by color Doppler ultrasound that you see there, the insertion of the umbilical cord. Another case at 13 weeks. You can see here the video clip. Is a cauliflower sign over there. At 12 weeks, another case. This is more prominent. That means that the hole in the defect is larger than the previous than before. Here you see the loops of bowel floating freely in the abdominal cavity over there, and the transvaginal scan at 12 weeks. You see there how the baby is jumping. And the baby is jumping over here. And you see also a system umbilical cord, and also these gastroschisis over there quite easily. You need to look for this color flower. And the management of gastroschisis is more easy because actually you need to look for amputation, spring, disruptive defect, second trimester anomaly scan, third trimester bowel assessment, but actually you don't need to do karyotyping because there is no association with genetic anomaly whatsoever. Moving to the lower part, you need to think in allantoid cyst that actually, is very rare, 1 to 2 every 100 deliveries. And this is the reason why you have this, you have the allantoid cyst over here, you have the coelomic space over there. And if you have this area over here, the allantoid is growing and is producing the cyst in the umbilical cord. Also, you have urine inside the umbilical cord, very large umbilical cords. You can see here, this cord weighs 700 grams. The baby weighed about 3 kilos, but you can see that there is a large edema that actually, is a very clue for the diagnosis in this case. When the baby is born, in a small one, you will see urine leaking through the defect over there. And in the first trimester, we described megacystics associated with umbilical cord cyst as a sonographic feature of patent urachus in the first trimester. And you can see here megacystic over there, the cyst in the umbilical cord. And in the second trimester, you can clearly see the connection between the bladder and the cyst. And this baby was born. This is a case from Professor Cafisi from Argentina. And this baby that we saw several years ago as well, you can see the megabladder, the megacystis, the connection, the cyst, and this baby died because of torsion of the umbilical cord over here. You can see that there was an hematoma and a torsion of the umbilical cord leading to intrauterine death in the first trimester. Several other cases, you can see here the connection in the first trimester at 12 weeks, and this is a quite nice view of the axial view of the bladder and the connection. And every time that you have this, you may have what is called the allantoid cyst. And actually, if the connection is too big, you may have even prolapse of the fetal bladder wall over here, as is shown in this case. Let me go a little bit further over here. So the same cases that you can see is very easy, and it's very characteristic feature that when you have this, you always will think in an allantoid cyst. And in this particular case, there was association with single umbilical artery. And this baby, I'm going to go. You can see here, and this is a more serious problem that actually, you can see this as a prolapsed bladder. When you have this, normally the differential diagnosis is omphalocele. And actually, we did the diagnosis prenatally of an allantoid cyst. But actually, when the baby was born, the neonatologist and the pediatric surgeon thought, there was a mistake in the ultrasound because actually this baby got an omphalocele. And actually they didn't realize that this was the bladder, the posterior wall of the bladder protruding through the defect. Here you can see, at the time of the operation, this is the urachus. You can see that there is a resection. The operation is not easy to perform, but need to be done because if not, the baby is going to be leaking urine throughout, the first days of life. And the last thing that we need to think is bladder extrophy, that actually the prevalence is 2 in 100,000 deliveries. In the second trimester, the diagnosis is very easy because you don't see the bladder and also a tongue-like mass in between the fetal legs. And this is really the posterior part of the bladder wall. In the first trimester, you can see a huge cyst just below the insertion of the umbilical cord. And after that, it ruptures, and actually the cyst disappear, and actually never, ever you will see a
You okay, Waldo? I think Waldo's frozen. I suspect maybe it's just a connection. So we'll just maybe give him a few seconds and probably he will realize that and maybe reconnect again. Otherwise, I give him a call.
Asma, while we're waiting for Waldo to reconnect, there's just one or two questions that have come in specifically in relation to your talk, and there are three questions that relate to talipes equinovarus, and I just call them out to you. The first one is the
position. So was it positional?
Yeah.
I mean, as I mentioned, I think diagnosis of clubfoot and diagnosis of club hand, I think is relatively straightforward in the first trimester. And it's not unusual that you see it in the context of, for example, trisomy 18. I think diagnosis of club feet is really difficult to see it in the first trimester because of the position. So could it be completely positional? I think if you confirm the diagnosis of clubfoot or fetal talipes in the first trimester, I don't think it's just positional. I've never seen that in the fact it's positional and then completely recover later, or the baby's born and it doesn't necessarily have talipes. I think that's might be the case later in pregnancy, but not in the first trimester, particularly when you have associated abnormalities.
So, and the other question was about follow-up. So if you saw it as an isolated finding in the first trimester, there was nothing else, would you wait to the second trimester to see whether in fact it's positional, or would you be confident enough to make a call and offer a chorion biopsy?
Well, if it's a clubfoot or talipes, I would offer CVS because some of the associated abnormalities might not necessarily be seen in the first trimester. And it also depends how detailed your ultrasound scan, whether you've done transvaginal ultrasound scan, whether you just relied on the transabdominal ultrasound scan. And also, I think the CVS, certainly the recent data suggests that the risk of miscarriage associated with CVS is very, very low, probably in the region of maybe 1 in 1,000, or even some studies, once you adjust for the potential risk factors of miscarriage, actually the risk related to the procedure is almost zero. There's no really excess risk of miscarriage, or I would say 1 in 1,000. And therefore, I would offer it to the parents, particularly if would that influence the management of the pregnancy.
Super. And I think we've got Valdo back. And Asma, I'll come back to with one last question, whether you would offer genetic testing for isolated polydactyly in the first trimester, but we'll come back to that question afterward. Or do you want to take it?
Well, I mean, Waldo's here, so we don't want to...
Yeah, well, I think we'll continue with Waldo and come back to Q&A, but just good to give you the heads up.
Yeah,
Waldo, we got you again.
The questions, I think you're muted, Waldo. Unmute yourself, please.
Okay, I'm very sorry about the technical problem.
Okay.
No problem. No problem.
Which one was the last slide?
Yes, I think you were talking about bladder extrophy.
Okay, but there are only few of them, really.
If I remember, I think with the features that you see in ultrasound scan in cases of bladder extrophy.
Okay, does mean that the last slides
with a black background.
Okay.
It was just after the surgical case. They thought it was an omphalocele, but in fact it was a...
I see there.
And,
I don't know.
and then the disappearing cyst was then the next slide.
Okay, let me connect back. I'm very sorry about this connection. I don't know what happened.
No problem.
problem.
Don't worry. Mistakes happen.
I don't know if you have there the screen.
We can see your
Yes.
we can see your desktop.
Okay. The desktop or the
No, just the desktop, and I think you are opening your slides, but
okay.
not the actual presentation yet.
Okay, let me go. Probably I'm going to get it here.
Yeah, that's it. We can see this. We can see your slides now.
Got the full screen.
Oops. I think that's the one.
Yes.
Yeah.
This one was that actually was diagnosed as an anomalies cyst in the first trimester by ultrasound. But actually, you know, at the time of the delivery, the neonatologist and the pediatric surgeon thought that there was an omphalocele. That actually, you know, I understand because it's not a common condition, and actually you can see there that the differential diagnosis is very easy to make. But actually, because they don't have the background, what happened in the first and second trimester, probably they made this mistake at that time. But actually, you know, soon after they realized that it was the bladder, they did the operation, and you can see here how they removed the urachus from this baby, and the baby recovered quite easily and was a very good prognosis in this case. Here, just to mention the extrophia, the bladder extrophy that actually, you know, is 2 in a 100,000. That means that probably in a lifetime you will see one, you know, if you're in a referral center, probably you can see a few cases. But actually, you know, here the clue is that you don't visualize the bladder, never ever during the pregnancy, normal amniotic fluid, and also a tongue-like mass at the level of the abdomen over here. And this is the picture you can see, like a tongue. You can see a protruding tongue over there, just below the umbilical cord. And actually, you know, you can see that the baby also have normally a lot of genital abnormalities. It was epispadia over there. And actually, when you see the X-ray, you will see that there is no padic. The pubis is not over there in this case, over there. This is the time of the operation. You can see that this operation can last for 8 to 10 hours and actually need a very, very large team of pediatric surgeons, including urologists, abdominal surgeons, and actually, you know, you see that this is a very difficult reparation to perform. And this after the operation, you see that the baby got a colostomy, and also they try to keep the testicle over here, and actually, you know, the big abdominal wall defect over there. And just to finish, this is just a case of an abdominal cyst, but actually the difference between the previous one is that actually you don't see the bladder in the baby's pelvis over there, just a huge cyst, just below the stomach over there. And this is the umbilical cord over there. The insertion was normal, but actually when you see the cyst is very large. You don't see anything else until the perineum over there and no bladder. And what happened here is that actually this is the baby. At the time the baby was delivered, was epispadia over there. You can see the penis over there and the scrotal sacs that actually, you know, normally is an associated imperforate anus. And when they did the operation over there, you can see that it's not just the bladder that is open, it's just the cloacal anomaly that actually you are able to see this. Actually, this is the appendix over there, and you can see a huge cloacal area over there that actually, you know, they presented this baby. The baby also had a very extensive operation, and actually is doing well at the time, but with colostomy over here. Therefore, just to finish, the classic patent urachus, you can see that there is an intra-abdominal and infra-abdominal cyst connecting with the bladder that actually when the baby is born is leaking urine. At the time, you know, they clamp the umbilical cord. You need to be very careful not to cut at the level of the cyst. When you see a larger connection, you may have what is called the prolapse bladder, and this is the abdominal, the bladder wall, the posterior bladder wall over there. And when you have a large cyst and no bladder, you need to think in bladder extrophy and also in cloacal extrophy as the two last cases that I showed you before. Thank you very much for your attention. I'm very sorry for the technical problems that we had during the presentation.
No problem at all. Thank you so much.
No.
Thanks, Waldo. It was fantastic talk, and really, you took it to a higher level. We were talking about the, the ectopia cordis and the bladder extrophy, and so really quite advanced. And it's fantastic. Thank you so much for sharing the cases. We're very, very nice. Okay, so should we just be conscious of the time? Why don't we have Nicola giving his talk, and then we can have maybe a discussion? Would that be okay?
Right.
So, as I mentioned, Nicola Volpi is a fantastic fetal medicine specialist. He was, well, I first met Nicola in London at King's College, London, or King's College Hospital. And Nicola went on and established fantastic fetal medicine clinics in Italy, and he's actually currently in Paris. And he and his team have recently been publishing fantastic work on first trimester brain abnormalities, particularly the posterior fossa abnormalities, which is an area where there's been a lot of recent development. And I really look forward to listening to your talk, Nicola. Thank you so much.
Great. Well, while I'm opening my slides, I'd like to thank Asma and Valdo and Simon for this fantastic webinar and very great content. I think you see my slides. Okay, so well, I will go quickly through this introduction because we have seen a lot of fantastic things so far. This is what it used to be the first trimester, classically, traditionally, fetal viability, CRL for dating, and nuchal translucency. But now we know what is not going on. Okay, now we see the evolution of ultrasound. The evolution of ultrasound is related to our skills in checking the baby in the first trimester. We are more and more used to that. We are having higher imagery resolution. We are having the advantage of transvaginal approach at this nowadays, and we are now driving Ferraris. If you remember how was the technology we used to deal with, it was more like a 500 Fiat. But now I think we are really driving Ferraris, and I don't know what are we going to do in the next future. And that's why we are improving our detection of fetal abnormalities in the first trimester. We have seen a lot of fantastic abnormalities. The percentage are saying that we are actually we now manage to detect more than half of the abnormalities already in the first trimester. And if we look into the fetal brain, this is the paper you mentioned before from Argyros and Gelaki. Well, more than half of the abnormalities related to the brain are actually detectable and detected in the first trimester. And they include acrania, lobar oroprosencephaly, encephalocele, and open spinal bifida. And we will look into that. This is just to give you a message that we can have different sensitivities for brain abnormalities. What is important is to have a strategy. The strategy means that one of the identified points to improve the detection of first trimester anomalies is to have a standardized anatomical survey protocol. This is the effort of several international societies, and this is the ISWOG paper from a guideline from last year, actually, and it is what is proposed to see on a routine basis while we are doing our first trimester screening in terms of anatomy of the head, just to look by axial view at the head of the baby to detect, to see how is the cranium of the baby, how is the midline falx, so the midline echo here, lateral ventricles, and the choroid plexuses. Well, as you mentioned already, Asma, we published recently a guideline with the World Association of Prenatal Medicine, and we actually agreed on the point of axial views, but we tried to push a little bit further the screening in the first trimester, trying to show to people that we can also have a look at the brain through a different way. Just on the same view of the nuclear translucency, you can have here these 3 anechoic spaces. This was suggested by the World Association of Perinatal Medicine. So first view, axial view, you can detect in about 100% of the cases these 3 types of abnormalities. You see here allobaroloprosencephaly. You see then you see here allobaroloprosencephaly, you see then acrania, you see cephalocele, but do not forget, we are measuring nuchal translucency, and more or less all the international societies agree that we need to do it, and we need to do it on the mid-sagittal view. And when you have the mid-sagittal, you have a lot more than nuchal translucency in there. So if you just focus on this, on this cranial posterior fossa, these 3 black spaces, you are actually looking at the brainstem, at the 4th ventricle that used to be called intracranial translucency, and at the cisterna magna. And it is about 15 years now that has been shown that just looking at that area, so that just looking at these 3 spaces, we can detect as early as in the first trimester the first changes that are actually predictive and related to open spina bifida. So this was a paper from Rabi Chawi. If I remember well, there were 4 cases showing that you have a prominence of the brainstem that is actually pulled down due to the open spina bifida modifications, the Arnold-Chiari modifications related to the open spina bifida. And if you just keep your eyes on that, you can also encounter other things like a cystic dilation of the cranial posterior fossa. You don't need to know exactly what's going on. If you are just screening for chromosomal abnormalities and you are measuring the nuchal translucency, you just look at that area. And when you look at that area, you can see some abnormal arrangement of the 3 spaces, either in sense of open spina bifida or in sense of cystic abnormality. When you see something wrong and you are just screening the patient, it should be the time for referral. So you should refer the patient for further evaluation and final diagnosis. And what we tried to describe when I was in Parma with Andrea, Elvira, and Professor Fusca and Professor Tullio Ghi was to standardize or to propose a methodology to detail, evaluate in a detailed way the anatomy. So what we call neurosonogram, we try to take the technique that we are using in the second trimester and to see what is possible to see using the same technique in the first trimester. What could be a proposal of neurosonogram. So actually, if we just follow the same type of methodology, we start from multiplanar evaluation by axial views, and you see that starting from the transventricular, you then have transthalamic, and then you fall into the cranial posterior fossa. Also, the International Society of Ultrasound, so the ISWOG, proposed to keep the same views already in the first trimester, just starting from the transventricular and just ending up to try to see the cerebellum. It is not very easy to see the cerebellum, especially at 11 or 12 weeks, but you can see, going through the axial views, how the anatomy could be depicted, how many details you can have. So lateral ventricles and choroid plexuses, you go down and you see the thalami and the mesencephalon and the aqueduct, and then you go back, and then you see also the cerebellum. So you see how you move your probe from transthalamic, transventricular, transthalamic, and transcerebellar views. And if you see at the ventricular system, at the aqueduct, at the 4th ventricle and the cisterna magna, you can notice, but we will have more image about that, that the anatomy is different than in the second trimester. So we should not think that we know the anatomy in the second trimester and we just translate it and we just transfer it in the first trimester. we need to know and to have the specific knowledge to adequately interpret the anatomy in the first trimester. So you see here what I've just described to you, thalami, midbrain, cerebellum. This is the simple transcerebellar view, but the very interesting thing, as already, I mean, in few lectures, Simon Meger presented even earlier than at this stage, you just can try to go a little further down, so a little lower than the cerebellum, and you will see other structures, and you will manage to see the fourth ventricle and this white bar, as has been called recently, so this white structure that is just beneath the cerebellum, and this is actually the choroid plexus of the fourth ventricle, and behind it you have the cisterna magna. So I don't want to stay too much on these because there are other pictures, and then we will put together the pieces of the puzzle. I tell you why. Because I want you to focus on what is the anatomy of the cranial posterior fossa in the first trimester, and we can analyze it just considering the very diffuse image we have on our embryology books. That is this one. This is the cartoon representing the fourth ventricle and the brainstem. So the brainstem has on its back the fourth ventricle. This is the floor of the fourth ventricle that is actually having a rhombic shape. And if you just take off the roof of the fourth ventricle, you can see like that. But if you take this piece, you will have this actually section. This is the brainstem. This is the fourth ventricle, the roof and the floor, or the floor, sorry, and the roof of the fourth ventricle. And we will see what will be the roof. Very important structure. We cut in the half, and we have the sagittal view. So let's see into the sagittal view. Here it is the Neisser embryology, and here we start from all the anomalies we will see. So you have the very beginning. This is the brainstem with the pontine flexor, and the roof of the fourth ventricle. Fourth ventricle is this one. The roof of the fourth ventricle is the primordial meninx. So the meninx primitiva, this red one, in the middle has this plica chorioidalis. That is where the choroid plexus will form. Now you will see an evolution of the meninx primitiva that will cavitate. So the liquid and the fluid that is then in the cisterna magna will come from cavitation of the meninx primitiva. And this is very interesting because at the very beginning, the black space of the cisterna magna is not due to the presence of to the cerebral fluid, but is due to cavitation fluid. And let's look into the fourth ventricle. The fourth ventricle develops in this way. You will have the meninx primitiva becomes like a velum, so becomes like an area membranacea. And the choroid plexus divides the area membranacea in two parts, the anterior membranous area and the posterior membranous area. The anterior membranous area is just above the plexus and will give rise to the cerebellar vermis. The posterior membranous area is just beneath the plexus and will represent an digitiform extension of the fourth ventricle that is actually the Blake's pouch. Then, at some point, the Blake's pouch will fenestrate through the foramen of Magendie, and just at that point, the cerebrospinal fluid will spread into the cisterna magna, and then the fluid will be mixed. So if you cut by axial oblique view, you will see exactly this. So you will have the brainstem, the mesencephalon in particular. Then you will have the black fourth ventricle. Then you will cut the plexus here that is a bar in axial view, and then you will fall into the cisterna magna. That's why you see this representation. This is how you cut the sagittal and the corresponding axial views. And here, then you can go for coronal views like we do in the second trimester. But this is a quick sweep that shows you cranial posterior fossa and then the most frontal sections. Let's focus on the cranial posterior fossa. You can cut in 3 ways. Let's consider the fourth ventricle as a referral. You can have an anterior coronal cut, a mid-coronal cut through the fourth ventricle, and then a posterior one. Very quickly, the anterior coronal cut is just the brainstem you see here. You see up here the aqueductus sylvius surrounded by the mesencephalon. And if you just go slightly backwards, you cut the fourth ventricle that has its typical rhombic shape. On the sides, you will cut the most lateral part of the hemispheres of the cerebellum and the most lateral parts of the chorioid plexus of the fourth ventricle. And above the fourth ventricle, there is the aqueductus sylvius connecting with the fourth ventricle through the isthmus. And just below, you will have the rest of the brainstem. At that point is the end of the pons and the medulla oblongata. And then if you go back, you will have the third cut. This is a view of the three the three corner cuts, anterior, transventricular, and posterior one, where you see now the mesencephalon, the tectum in particular of the mesencephalon, the aqueduct, the cerebellum, and this is the plexus. So this is the typical shape. We'll see better later. And this is actually the very posterior and lower end of the fourth ventricle, that this is actually, as we say, the Blake pouch. Then we finally go to the mid-sagittal view. And the mid-sagittal view, as we have seen, just behind the encephalon, you will have these 3 spaces in the cranial posterior fossa. These are visible in our routine evaluation of the mid-sagittal view of the nuchal translucency. And you have the brainstem that has been measured in several papers. And the other 2 spaces are the fourth ventricle and cisterna magna. They have been called also the space behind the brainstem, so the BSOB, brainstem to occipital bone space. We will see why. So let's talk about abnormalities now. We know how is the normal anatomy. What is the abnormal anatomy? The big deal of the first trimester has been now, in the last 10 years, open spina bifida for these cranial posterior fossa issues. We were used to deal with bananas and lemons in the second trimester, but here we have something different. We can look into the anatomy and we can notice that what happens in case of open spina bifida is the Arnold-Chiari 2 abnormality, or better, all the structures of the cranial posterior fossa are pulled down through the foramen magnum, through the basis of the occipital bone. In particular, you have just these very dry posterior fossa with the brainstem pulled down, and all the fourth ventricle and cisterna magna are actually more pushed back and squeezed. And this is a nice pictures from Fred Ushakov a few years ago on its website. They are showing exactly this phenomenon, how the brainstem is pulled backwards and compresses the posterior spaces. While we started to look at the intracranial translucency, so specifically at the fourth ventricle, we realized that it's not every time very easy to be seen. And therefore, that's why we prefer to measure the space behind the brainstem, so the so-called BSOB. When you have open spina bifida, this is a paper from Robert Lachman 15 years ago, he showed that an increase of this ratio, so the brainstem that is prominent against the posterior space, so the BSOB, was very much predictive of open spina bifida. So you can see it here. You see only 2 spaces in this case, and you have a very increased ratio. And then you see here, as also in axial view, you can see all the anatomy here pulled backwards. So this has been also called crash sign, but the group of Simon tried to quantify the crash sign, so the distance between the aqueduct and the occiput, and we put together our data to show what would be the best measurement to predict open spina bifida. And guess what? BS to BSOB was the best one, with an area under the curve of 0.99, predicting open spina bifida. Very nice numbers, but practically, what do we do when we see an increased BS to BSOB or a crash sign? We just remember that this could be the sign of open spina bifida. So we look at the spine and we can find either a normal spine, the video is not going, or an abnormal spine. You see here how the abnormal spine is showing this little bubble that is actually the sign of a meningocele, or here myelomeningocele in coronal and axial view. So very straightforward pictures, sometimes not so easy. Sometimes the 3D could be helpful, could be efficient, but I want to focus on the cranial posterior fossa. Cranial posterior fossa in this case was actually showing something strange. There was this patient sent to me for increased nuclear translucency, but actually you see here, there was a cephalocele. But with a cephalocele that is actually a neural tube defect, we should have an increased BS to BSOB. But here was exactly the opposite. So you see that the ratio was reduced. So I was trying to find out why was this happening, and the answer is that neural tube defects are a wide family, but in particular with cephalocele, we talk about carry 3 abnormality rather than 2. That means that the herniation is not through the foramen magnum, but is from somewhere else. And this somewhere else could change according to the subtype of the cephalocele. So you can have a very specific and peculiar crash sign, very peculiar BS to BSOB, and you have to consider that it's not every time the same. Sometimes you encounter something completely strange, completely weird. In this case, I was astonished to see how this cyst was looking like a cephalocele, but was having a mass effect. You see how the brainstem is pushed away. So very strange, not every time the same things. So last topic, look at the BS to BSOB, look at something strange. This is a paper from my ankle unit. My wife was working there at the time. I was already in Parma, but as you can see, this is a family family disease, the cranial posterior fossa. And in this paper, they showed that if you look at this population of 21 fetuses with only 2 spaces visible rather than 3, some of them were having a very reduced BS to BSOB, and some of them were having an increased one. So it was increased in case of cephaloceles or open spina bifida. It was reduced in case of chromosomal abnormalities or in case of cranial cystic anomalies of the cranial posterior fossa with follow-up. So we don't know these because we don't have the follow-up, but we know they are chromosomal abnormalities. Better, this paper from Robert Lachman and again from the same group has shown that if you have increased spaces on the posterior part, so intracranial translucency or BSOB increased, and you make the BS to BSOB ratio, you can predict Dandy-Walker malformation, but also it is increased in Blake pouch cyst. Very interesting thing. These are 2 cystic abnormalities that could be visualized in the first trimester, but they are having very different prognosis. This is axial, sagittal, and this is coronal view of cystic enlargement of the 4th ventricle. And this is the comparison with the normal. So Dandy-Walker malformation, Blake pouch cyst, 2 different entities, but they are showing up with an enlargement of the posterior spaces of the first of the 4th ventricle in the first trimester. What are the differences? The difference is mainly in the vermis, and another difference. This is the comparison between the 2 prognosis, but I will be back into that later. The other difference is the torcular aerophily position. So we can see the torcular aerophily position. We can see the straight sinus and the tentorium, where the torcular aerophily represent a atomic landmark of the tentorium cerebellum, and the research and the pathology tells us that in case of Dandy Walker malformation, the tentorium is supraelevated, the torcular aerophily is supraelevated. And this was from the same group from Bari, from my uncle, has been shown that in case of Dandy Walker malformation, the tentorium could be visualized already in the first trimester as supraelevated, and the demonstration was through this angle that was the brainstem to tentorium angle that was reduced as lower as the tentorium was supraelevated, as you can see here. And this was a good tool to distinguish Blake pouch cyst from Dandy Walker malformation in cases of abnormal BS to BSOB. If you measure the same thing in case of open spina bifida, well, it was the other way around. The tentorium was pulled down, so the angle was not reduced, but was actually increased. So this is another marker that could be used to distinguish, to visualize and predict these two abnormalities. But it is not enough yet. I think that the real deal is to distinguish the embryology of these two abnormalities, in particular, Dandy Walker anomaly and Vermeer hyperplasia, that are those with with worst prognosis, are coming from an abnormality of the anterior membranous area, and the Blake pouch cyst is coming from an abnormality of the posterior membranous area. So this is how you look. It looks like in the second trimester, then the Walker malformation. You see that you can observe that it is a deal of the anterior membranous area, because this is distended and expanded, and the plexus is pulled down and externally. This is different in Blake's pouch, where you have the plexus close to the cerebellum. So is possible to visualize these things in the first trimester? You need to change your point of view. If you look at the cranial posterior fossa from the posterior, with a posterior approach, possibly transvaginally, you will have a new world, the access of a new world. You will see clearly that black space was the brainstem, now is isoecogenic, so it's gray, and it is the mesencephalon pons and medulla oblongata, and you will see the aqueductus sylvium, the mesencephalic tectum, isthmus, fourth ventricle, and you see also the anterior and posterior membranous areas divided by the fourth ventricle. You see here the protrusion of the fourth ventricle that we call Blake pouch, and you see the cisternal angle. This is very interesting, and the research has been measuring this stuff. So few groups tried to find out markers to distinguish Dandy Walker from Blake pouch. I will go through I think, the most useful ones. I think that we have been talking about BSOB, 2 spaces rather than 3, supraelevated tentorium, but has been shown, has been proposed by Dario Palladini, an increased pontovermian angle for Dandy Walker abnormality. Has been proposed by an Austrian group, the measurement of the anterior membranous area. This is a case of very much increased cystic dilation of the fourth ventricle, and you have increased pontovermian angle, and you have elongated anterior membranous area. But I want to show you how sometimes already at 10 weeks could be very clear that here the cystic dilation is of the anterior membranous area rather than the posterior. I don't have the outcome of this because after 1 week there was spontaneous miscarriage, but this is the last concept. One marker that has been proposed by the literature, I think, it will be the most useful one, after you observe an abnormal BS2-BSOB to distinguish the two entities is the choroid plexus. As I've shown you before, the choroid plexus should be just beneath the cerebellum. The choroid plexus has this typical shape of the fourth ventricle, has this typical shape of a Japanese temple arch. And if you use 3D, you can see it also with some specific filter, BCIA, again, the same shape. But what we see is, by axial view mainly, the transverse part. That's why it appears like a choroid bar. If you have an abnormality, you can see that in case of Dandy Walker malformation, as you have a dilation of the anterior membranous area, you have that the plexus is pulled externally and downwards. Whereas if you have a Blake pouch, the dilation is from the posterior membranous area and it comes up surrounding the plexus. So the plexus will be a little bit displaced, but will keep a maximum V shape, but will not push completely away. And these are examples. The previous were examples from Paolo Volpe's group, our group, and these are examples from Dario Palladini's group, where you can see this cystic abnormality Dandy Walker, where you have the plexus just external, and here open spina bifida, you see the plexus disrupted, but it is kept internal, and the same happens with the Blake pouch cyst. So just to conclude, I want to show you how it would appear, the cranial posterior fossa, earlier than 11 weeks. Using 3D or also with 2D, we can see the rhomboencephalic ventricle and area. This is just to tell you that we cannot find abnormalities if we don't know how is the normal anatomy. I think the other speakers agree with me, but I've been dealing with a lot of other speakers older than me saying, well, I think this view doesn't mean anything. This view is not useful. But if you don't know the normal anatomy of that view, you will never be able to see through the abnormalities at that same age. And this is my last slide. At 7 weeks, you already see and distinguish the rhomboencephalon, the mesencephalon, the dencephalon, and the telencephalon, hoping to have more and more details in the next future. And I thank you very much for your attention. I hope to have been not boring you in this half an hour talk.
Fantastic. Thank you so much, Nicola. I think people, I mean, if you look at the comments, people loved it. So loved the talk. And I really think it's nice to push the boundaries of our knowledge of the first trimester anomalies. And I mean, I've been following the comments on the question in the chat. And even for sonographers, I know this, don't people talk that this is just too much details or too complicated. I think I personally strongly believe that you would identify things if you've seen it. The eye will identify something that you've seen it before. But don't worry. I think this Eugenie James, I think is talking about if in a low risk clinic where we have 20 minutes transabdominally, as a sonographer, what will be your key points to look for axial images? I think best, especially for rhomboencephaly and T-wall defects, which are suspected in scan in the first trimester, and where they will miss them. Okay, so I think we will address this point. But Nicola, that was fantastic talk. Thank you very much, and thank you really for sharing. This is sort of the latest really development in our understanding of, you know, the brain anatomy, particularly early pregnancy, the brain development, and maybe markers of associated brain abnormalities. Particularly the posterior fossa anomalies is really something that's quite difficult, I think. So if you want to give sort of key messages to say, you know, if you're not the person who's super experienced in fetal medicine,
absolutely,
neurosonography, what would be the normal of the sonographers, what things they should look at and where they should refer?
Exactly. Yes. Thank you. I mean, this is a very important message. I think that we need to separate the routine evaluation and the advanced evaluation. What you have seen in my slides is a process of passing from the basics to the advanced. I mean, what I would suggest is for sure to follow the guidelines saying that you need to start from an axial view of the head, and you got a lot of information from that. the simpler would be the easier to be done, but with a little bit of knowledge of what you are looking at. The second section that is not suggested as a routine from all the international bodies is the mid-sagittal, or better, is suggested for nuchal transducer measurement purposes, but I think that we have already there the 3 spaces. I'm not saying you need to look at the cavum belli interposity, at the encephalon, at the cavum septipellucidity on that view. You need to look at 3 anechoic spaces that should be roughly equal in size and similar in aspect. If you see that these are weird, so there is an abnormality in this balance between the 3 of them, then you ring the bell. And this is very quickly, few seconds. The advanced part could require a lot of time and transvaginal approach, but I don't think this should be required to the screening operator, to the basic routine evaluation in the first trimester. I think I have addressed.
Yeah, that was fantastic. That was really good. Thank you so much, Nicola, and really very clear messages. I'm going to bring sort of Waldo to the discussion because there are many questions also to his talk. And there's one of the questions, Waldo, is about, well, how do you differentiate between a bladder cyst and patent urachus?
Well, actually, I don't know the term bladder cyst. The only cystic structure that I'm aware of is the one of urethrocoel. But actually, when you talk about, the allantoic cyst, really the allantoic cyst is within the umbilical cord and in close connection to the insertion of the umbilical cord because of a patent urachus. That's the definition of that. There was another question asking for urachal cyst, but actually the urachus is the fibroid tissue that remains and is between the bladder, the dome of the bladder, and the section of the umbilical cord. That means that the cyst is inside the baby's abdomen in the anterior wall. But the allantoic cyst is just outside the baby's abdomen and in close apposition with the section of the umbilical cord. That's the difference between that main. Actually, you don't have allantoic cyst in neonates because actually they go straight to the operation by the urologist. And actually, the urachal cyst is normally a diagnosis that you can make later on in life, probably in babies or probably in adults even. And that's the difference between the two of them.
Fantastic. And in fact, you answered another question, which is by Dr. Bala. Is allantoic cyst and urachal cyst the same? And the answer is not. And you beautifully sort of illustrate the difference between the two. Fantastic. That's great. Is it possible to differentiate between omphalocele and umbilical hernia in the first trimester? That's a question from Dr. Nando.
Oh, yeah. Well, it depends because after 12 weeks, actually, you shouldn't have any hernia. It's abnormal to have, any protrusion of the loop of bowel. But between 10 to 11 weeks, it's quite difficult to do. That's why, if it is prominent, you should have a scan. And also you need to point in the four features that actually I mentioned. If there is kyphoscoliosis, if the heart is within the defect, or if there is other anomalies in the baby. But actually, it's very difficult to do at around 11 weeks. That's why, it's better to have a follow-up scan 1 week later, and then everything is going to be sorted out.
So when would you give the diagnosis of umbilical hernia?
Well, actually, I'm talking, when you talk about umbilical hernia, probably you're referring to physiological hernia?
Well, I mean, I think I agree with you. I wouldn't don't routinely use the terminology, and we published a few years ago about the fact that exomphalus actually can resolve, especially if it's small, containing only bowel, particularly early gestation, particularly when the nuchal is normal and there is no genetic abnormalities, and there is high rate of resolution. But when would you actually, during the pregnancy at a later stage, would you ever use the terminology umbilical hernia? And when would you?
No, it's omphalocele, because actually, when you have an umbilical hernia, Normally, there is protrusion when the baby is crying, when the baby is increasing the abdominal pressure, and then you have the umbilical hernia over there. But actually, when the baby is resting, everything disappears. But doesn't happen in uterus. That's why, I'm not familiar with the term that actually they're using. It's probably a pediatric term.
Yeah.
Actually, it's very difficult to get, this diagnosis.
Simon, I think Simon, he's had, yeah, Simon, you want to come in? I think.
Yeah, I agree with Waldo. He's just in concluding comments. It's not a term used prenatally. I think omphalocele, there's omphalocele minor and omphalocele major. Omphalocele minor being bowel migrating into the base of the umbilical cord, rotates 270 degrees, returns to within the fetal abdomen. If it fails to return and rests within the umbilical cord, we refer to that as the term of omphalocele minor. So it's not a lateral fold failure of closure, whereas omphalocele major is a failure of closure of the lateral folds during embryological development. And for the umbilical hernia, as Waldo makes reference to, it's a postnatal term when the baby coughs, increase in abdominal pressure. And I think it relates to a defect in the musculature of the anterior abdominal wall, unrelated to either embryonic folding or unrelated to return of bowel in the umbilical cord. It doesn't happen prenatally and not described prenatally. So I agree with Waldo.
Yeah. And maybe one.
But if I could actually, sorry, Asma, if I could ask Waldo, a question with relation to seeing the omphalocele minor. So let's say a patient comes to you on Monday morning, you can see a loop of bowel in the base of the umbilical cord. And Nicola, also be very interested in your take on this as well. You see a loop of bowel in the base of the umbilical cord. My question to you is that something that at 13 weeks of gestation that you would proceed directly to offering a chorion biopsy? And I'm assuming that you've established that this is bowel in the base of the umbilical cord, not liver. And my question is to you, if everything else is normal on the baby and she's low risk of aneuploidy, would you offer chorion biopsy at 13 weeks of gestation?
Well, in my particular unit, we don't, because actually, we should go for NIPT first, because actually it's not invasive. But actually, you need to look for the general features in the baby, nuchal translucency, nasal bone. And actually, you have a trisomy 13 or trisomy 18 in the first trimester. We are not missing the diagnosis. Therefore, it's very difficult to go for an invasive testing at the gestational age. Probably we will do NIPT, and if there is something else, for example, the heart, that actually we examine after 16 weeks, if there is something else, probably then we will go for an amniocentesis.
Yeah. Nicola, because we do offer CVS.
Oh, well, I agree with the concept that just Valdo said. The concept that you said also before is also valuable. I mean, you are at 13 weeks, so you don't know what will come up in the next weeks. And therefore, I think that it really is a challenging counseling with the patient that has to choose then, because we generally offer invasives for all anomalies. The option of cell-free DNA, it is also valuable, but of course you need to consider that something could come up later on, even if we are very good in detecting anatomy at this early stage. Anyway, you need to consider some possible progressive anomalies. Therefore, I explain to the patient all these issues, and we decide, I mean, according to their wish. In Italy, there is a very strong issue with legal medicine. Therefore, we really counsel and ask patients what they prefer, explaining pros and cons, and we just write down everything with signatures.
Yeah. So Nicola, if you find the posterior fossa cystic structure in the first trimester, of course, if there's associated abnormalities, you would think about aneuploidy or genetic syndromes. What if it's isolated? So nucleus is fine, NIPT is low risk, the rest of the baby is fine, and just cystic structure in the posterior fossa at 12 weeks.
Yeah, well, it could be a Blake pouch, and it could change in a positive and a favorable way. Therefore, it is recommended to see again at 16 weeks, let's say. So in Italy, we have the limit for termination at 22 weeks, roughly. And therefore, we have those time. When we consider then something is not definitive, we prefer to see again. So of course, if you have a cystic dilation with other abnormalities, probably the risk for chromosomal abnormalities will be increased and all that stuff. So these are quite straightforward cases. But as you said, when you have a very small dilation, what to do? It is even more difficult to not make the patient anxious in the meanwhile, waiting for the follow-up. So I think that is the big difficulty, rather than trying to find out at the end the final diagnosis, because patients, they get mad and go to other professionals, and they start to go around and they go mad for an invasive test. So it is very important counseling again here also.
Yeah. And I think just maybe to reiterate that when it is isolated and you've done your really detailed first trimester ultrasound, including transvaginal ultrasound, I think we just need to be careful, because some of these cases, when you follow them up at 16 weeks, it disappears and the brain is completely normal. So exactly. I think we just need to be careful, because, certainly some people might even opt for termination of the pregnancy if you tell them that they maybe have a brain abnormality in the first trimester.
Absolutely.
Yeah. Okay, fantastic. Just a question to Waldo. Is there any criteria to differentiate between physiological umbilical hernia and omphalocele at 9 to 11 weeks?
Well, I mentioned that in one of the slides, that actually if you have an omphalocele with containing liver, it's absolutely abnormal. That's from the beginning. Doesn't mean that you will be concerned, that actually this baby got, even at 10 weeks, a large omphalocele. Also, I mentioned kyphoscoliosis because, that's another thing that actually can point out to the diagnosis of a serious abdominal wall defect, or probably, affecting the body stock. And also, just check the position of the heart. Mainly, that's going to be the main things. But actually, it's very difficult to do the diagnosis at 10 weeks. And therefore, just do a follow-up scan at about 12 weeks, and everything is going to be cleared up in this particular case.
Yeah, I mean, Simon, you're a huge advocate of the 10-week scan at the same time as NIBT. So and we know that, of course, if you have, let's say, increased nuchal or fetal abnormalities that early, that perhaps we shouldn't offer NIBT, but we should just go for CVS. Any of the speakers, or if you find physiological or sort of hernia or appears on omphalocele at 10 weeks, number one, does it influence? You still offer an IBT, detail the patient, or you just say, okay, come back at the 12-week scan?
Okay. If I can first of all just qualify about being an advocate for the 10-week scan, if I could maybe reword that and say that women are an advocate for early testing for Down syndrome, and we necessitate doing a 10-week scan before we draw blood. We never set out to screen the population by doing a 10-week scan. It happened by women's desire for moving and shifting, and I think it's probably going to happen globally. So it happened by necessity rather than by design. Just a small splitting hairs comment to make, but a relevant one. Just broadly to comment on a couple of things that have just come up in discussion relating to the fourth ventricle and the omphaloceles. With regard to the question asthma and the omphalocele, the guidelines differ as to what is used as being the cutoff and which bowel returns to within the abdominal cavity, and when is the trigger to proceed with invasive testing. For most of the physiological omphaloceles that we see, it's around 10 weeks, 3 days and 4 days. That's the median. So by 10 weeks and 5 days, 10 weeks and 6 days, for most of them, they've returned. So if you look at the ISUOT guidelines, 12 weeks in my mind is an acceptable cutoff. But if you look at the American guidelines, AIUM, they use 13 weeks as cutoff. And Nicola, I'm not sure what the World Association Perinatal Medicine guidelines are, as the cutoff is defining the physiological event should be complete. But at the end of the day, if you're faced with an omphalocele, which you've done a detailed high-frequency endovaginal scan, there's no associated abnormality. My feeling is that you should not offer them invasive genetic testing by CVS. My feeling is that you should wait for 15 to 16 weeks and offer them amniocentesis. And the rationale behind that is, first of all, Wilder made the point is that 13 and 18, you'll pick up on scan on NIPT. The associated abnormalities with regard to major abnormalities, chromosome abnormalities, I know there'll be some you will miss, but for most you will pick. The point, the elephant in the room is Beckford-Wiedemann. Now, if you look at it, if it just contains bowel, particularly in the setting of an IVF pregnancy, more than 50% of these with isolated omphalocele containing bowel alone will turn out to be Beckford-Wiedemann. And you cannot test on CVS, so you end up having to needle patients twice. So I think we need to change our mindset on what we're doing with regard to omphalocele minors who present with loops of bowel in the base of the cord that is isolated, particularly in the IVF pregnancy, because the vast majority of these are going to be Beckford-Wiedemann, and you need to do methylation studies, and you can't do CVS. So you should hold back and wait till 15, 16 weeks and offer invasive genetic testing and do a CMA and methylation studies. Then just come back with regard to the point about the fourth ventricle. I mean, it was a fantastic, brilliant talk covering both embryology and sonography. And in fact, if you look at it, the dilated cerebral fourth ventricle is far, far more prevalent than the reduced IT fourth ventricle or absent intracranial translucency. And it's a bit of a dilemma in a sense. And I don't think there's necessarily clarity that if you have an isolated, obvious dilatation of the fourth ventricle, whether you should proceed with invasive genetic testing. We all know that the big ticket item is digonic triploidy, because 95% to 99% of digonic triploidy will have a dilated fourth ventricle. Then if you move to 18 and 13, it's the order of about 80% and 50% respectively. Again, you'll pick these up on scan or if SNP-based NIPT. Then you're left with, is it a Dandy Walker or is it a Blake's, and should I offer invasive genetic testing? I think it's a really difficult one. And I've learned a lot by listening to Nicola's talk in terms of the embryology of possible differential diagnoses. And I think looking at angles, as Dario suggested on that paper, which was 4 cases in that paper, looking at angles at tiny structures in the first trimester, I don't think we can apply that in the screening context. I think it's promising at looking at the aqueduct of Sylvius because it's enlarged in the case of Blake's and it's absent in the case of Dandy Walker in their small series. But we looked at our series of 3 cases and it was exactly the same, that the aqueduct of Sylvius is absent in the case of the dilated fourth ventricle with a negative chromosome analysis forming CMA and a CVS. So I think that shows promise in the future. But at the end of the day, I don't think we can make these diagnoses of posterior fossa anomalies in the Blake's pouch, Dandy Walker continuum in 2024. And I'm sure Nicola will agree with me. And finally, as a passing comment, we've spent 15 years looking at the intracranial translucency in screening for spina bifida. And the first 4 cases that was described was absence of the intracranial translucency with a 100% detection rate of spina bifida by looking at the absence of the fourth ventricle. If we look where we are today, there are several papers saying that, in fact, only 15 to 20% of babies with spina bifida will have an absent fourth ventricle. So I would say to you that the intracranial translucency, absence of the fourth ventricle, is in fact a lousy marker for spina bifida. It doesn't stack up. Now, it's interesting because you say, well, why is it that we spent 15 years looking at the intracranial translucency? Well, the answer is because we thought the answer would be in the posterior cranial fossa, because when you're screening for spina bifida in the second trimester, you're looking at the cerebellum, banana-shaped and obliteration sternum magma. Surely the same principle applies in the first trimester. The answer is it doesn't. The answer is in the first trimester pregnancy is in the midbrain and the brainstem. And the first group to report on that in the Axel section, and thank you, Nicola, for quoting it, was Martha Finn's paper, who published in 2011, that its midbrain shift is actually the winner on it. And I was delighted that your meta-analysis came up with the same conclusion as our meta-analysis, is that midbrain and brainstem shift is actually the most sensitive marker. So I think going forward, if you're going to screen for spina bifida, you need to screen by looking at the brainstem. For me personally, I think looking at an axial section and looking at shift on a BPD, everybody in this room knows what a BPD looks like. And if it's shifted posterior, which was later described by Fred Ushakov, the same sign as the crash sign, I think people learn that quickly. But for those who are in the specialist arena in dedicated units, looking at 3 spaces, looking at 6 lines and understanding all of those is very powerful by looking at the brainstem to the brainstem occipital bone distance. But the learning curve is just much longer than understanding the shift on the axial section. At the end of the day, I think both of them are good, but we need to shift our brain thinking into looking at the midbrain and brainstem for spina bifida, and dilatation of the fourth ventricle has been an extremely powerful marker for the common aneuploidies, microdeletions and duplications. And when you've excluded them, you're in no man's land trying to work out what's going on. But that talk by Nicola has given us a beautiful understanding. Potentially, if we can marry the understanding of embryology with sonography, maybe in the future we will get closer to these diagnoses.
This is our hope, yes.
Yeah.
Fantastic. Thank you very much. I'm just conscious of the time. It's been about like almost 2.5 hours on this webinar. I have to say, I really enjoyed it. I think many people did, if you look at this comments and the messages. Huge thanks to people who joined us today for the webinar, and fantastic talks by amazing speakers. And I'm really grateful for the speakers to actually, give up your time on the weekend and prepare these talks to share your expertise with us and share your latest research. So thank you very much. Just some housekeeping. As I mentioned, the recording will be available on the Geographic Health, the website, free. There'll be feedback. You can get certificate of attendance. And again, thanks to the sponsor, GE, and to the team behind the scene, my amazing team who really work hard, and the fellows to make sure that this webinar goes smoothly. So just a huge thanks to everybody, and thank you so much. Enjoy the rest of your Sunday. Simon, I know it's very late for you on Sundays, like after 11 o'clock. So hopefully you have a good night, and I'm sorry that I hope that we didn't keep you awake for long.
No, enjoyed every minute of it, Asma, and a big thanks to Nicola and to Valdo. Brilliant presentations, learned so much, and thanks very much for joining us.
Thank you.
Good night to you all.
Thank you very much for the invitation.
Thank you very much. Thank you.
Thank you. Thank you for doing this webinar. Thank you. Bye-bye.
Bye.
Bye, folks.
Recording stopped.